some yogurt in the fridge for you. If you ever want to switch it up to something else, let me know. No, I know, I didn't.
Are you ready?
You made it.
One live. Microphone.
Good. Good, yeah.
Good morning, everyone. Welcome to the Prostate Cafe. I'm Dr. Dattoli, and I'll do my very best to answer any and all questions as it pertains to prostate cancer. This forum is typically on a last Friday of every month. But anyhow, with respect to those questions, does anyone have any burning questions or concerns at this time?
I can wait. Yeah, I have two questions, but I'm Richard Allen. We had a consult the other day.
Okay.
So, no, I just wanted to know what's the percentage of patients that have complications after the radiation therapy? Is there low, or I mean, I hear stories about radiation being bad news, can affect other organs, your colon, your bladder, things like that. So I'm curious about.
Okay. So he's asking about complications as it relates to radiation. Radiation has come a long way, and not that long ago, let's say 30 years ago, it was actually quite primitive compared to today. And we didn't have all the technologies that we currently have. And in fact, you all may or may not have seen what we call plain X-ray, which is before CAT scans and MRIs and all those technologies. And even with the beginnings of MRIs, and of course the CAT scans were already there, even still, radiation was using plain films to target areas, which basically means that you'd be targeting everything in between the field. I mean, front to back, sideways, every which way. And that changed with the development of something we call three-dimensional conformal radiation, which was the first big advance in prostate cancer, which got into more focused radiation. And more recently, we've gotten completely high tech. And I would say the current gold standard is using something we call IMRT, which stands for intensity modulated radiation therapy. And with that, you no longer use plain films. You typically incorporate all the data set from MRI information, CAT scans, ultrasounds. It all gets fused into a certain pictorial, and then a plan is generated. And the plan is generated by physicists and dosimetrists after it's been subject to AI to run through millions of permutations of how a field would be the best field. So you put a little dot somewhere and then you ask the computers, what is the best way to get to that field? And so that was IMRT. And, there are other types of radiations, which we call external beam radiation, meaning the radiation's coming from the outside. And there's protons, neutrons, photons, electrons. There's a whole sundry of types of doing it. And they're all made to shoot from the outside and hit targets on the inside. We, right here in this center, we were actually the first freestanding center in America to do something called IMRT that I just mentioned, intensity modulated radiation therapy, which was initially developed by Sloan Kettering in New York, where I have a relationship, and the University of Michigan. And so we were kind of on the forefront of that. And what it did for us is it gave us the opportunity to continuously change and improve and advance. And initially, I had recruited the team from Sloan Kettering in New York, and they're still part of the background. I worked with some brilliant physicists there to develop what we have today. Today, we use a type of radiation we call DART, and it stands for Dynamic Adaptive Radiation Therapy, with its sole intention being to hit those targets and to not miss. But targets of the prostate are moving around, and that has a lot to do with the fact that the prostate is surrounded by structures and organs that move. And since we shoot our microbeams at targets the size of dots, you can think of them as pixels or voxels on a computer screen. Well, any little perturbation of the dots is going to offset your beautiful plan. And so we try to move in conjunction or in sync with your body's motion, because everything's moving. Even degrees of pelvic breathing, if you just think about it, if you put your finger between your belly button and your groin, you move more than a dot. So with all of that having been said, complications of radiation have diminished dramatically. Okay, with the use of IMRT in most centers in America, the complications of old are just not really there anymore. We can never quite predict. I mean, you're going to always have a certain patient who's going to have some problems, but most problems are temporary. So radiation does bring with it some inflammation. And as you all know, or you may not know, the prostate is just surrounded by critical structures which can be affected by the inflammation. So while we don't treat those other organs, the prostate will get inflamed, and it'll share its inflammation with some surrounding areas, which could cause some more frequency of urination. It could cause more frequency of bowel movements, things like that, because the bowel and the bladder are so close. But really, we may not see any side effects at all with our current versions of radiation. And if you do have them, they're temporary. But again, there's always going to be a percentage, where you could have complications, where there can actually be injury to the rectum, injury to the bladder. We use a special gel which we put between the rectum and the prostate, and it spaces the area, and that's another way of reducing potential exposure to the rectum. We think that's mostly important when we do brachytherapy. And the reason for that is brachytherapy, by the way, is the most precise type of radiation. There is no more precise type of radiation than brachytherapy, where you put these tiny little radioactive materials directly in the tumors. And it's more precise than protons and high energy photons and everything else out there. But the problem is, when you do the brachytherapy to the prostate, well, the prostate sits right on the rectum. And so as precise as brachytherapy can be, but you're putting the sources right on the rectum. And so what we do is, before a brachytherapy procedure, we use a spacing device. The one we prefer is called Barrigel, and it spaces the rectum from the prostate. And we think that is, a big benefit to patients. We just don't see much in the way of rectal problems. The only problem we ever see with that now is the potential bother that the gel caused. not the radiation, because it is foreign. It's a foreign body, sitting right there. So I think if you look at current data with radiation, it got a bad reputation in the past, but it's really changed, and there are very few side effects as it pertains to radiation as is being currently delivered in America.
So when you talk about targeting like the cancer on the prostate, I think if I heard you right in our consult, you said that the prostate can be saved. The organ can still function.
So he's asking about the potential function of the prostate after radiation. And what I do, is we treat the entire prostate gland to a microscopic dose. Okay. And we do that because while we may know that there's a mass or a cancer on the right side on the top of the gland or in the mid gland somewhere, by the same token, every part of the prostate could be potentially harboring a microscopic cancer. And so we always treat to a microscopic dose and then boost the tumors themselves with both the DART that we deliver here, and we hyperdose that, and then we dose escalate with brachytherapy to the tumors per se. And with that being said, it does allow the rest of the prostate to continue to function because the rest of the prostate can deal with a microscopic dose. It can handle that. Cancers can't. It's really interesting because I know when patients go somewhere else, there's a big competition with radiation and surgery, radical prostatectomy. So the urologists are going to take, shots at the radiation and maybe vice versa. But what typically happens is when I see a patient's notes who has had radiation, at least of my patients, and he goes elsewhere and is seen by a urologist who doesn't know they had the radiation, they'll say that the gland is very pliable and smooth. And by the same token, those guys who know you've had radiation, they're going to say, oh yeah, it's a piece of charcoal down there. And it's just the way it is. It's the competition amongst the fields. But the prostate, by the way, makes most of the ejaculate. And, it's a sexual organ. As you probably know, it's the G spot in men, and it has a lot to do with the orgasms. And it also happens to carry the nerves and vessels to the penis for penis engorgement and innervation. But the ejaculate can suffer. Okay. And that's interesting because many of you may have had, if you've had prostate cancer, you've had a biopsy. And sometimes the biopsy itself can affect the ejaculate. So it's very finicky as it pertains to that. You have to understand that there are these tubules that go through the prostate called ejaculatory ducts. And if any needle, hits one of those ejaculatory ducts, in the path of the needle, it may scar down a little bit and block the path. And so it's commonplace for men having problems with prostate or cancer to be treated and then have a diminished ejaculate. So I know most of my patients will write, 5-10 years down the line that their ejaculate is diminished in volume and changed in consistency. But what's actually coming out is mostly sperm because the testicles still are making sperm, and it gets into the prostate, which then gets into these storage containers above the prostate that we call seminal vesicles. Interestingly, many men think, that they've had radiation and so they're sterile, and they're not. And I've had many, many men over the years, have children that they didn't expect to have, wantingly or unwantingly, and because they are still fertile. So, but typically the ejaculate is diminished, but that could be also something that happens with age, so as age happens, so does the ejaculate diminish. There's also a category of drugs called alpha blockers, which are commonly used for prostate. Many of you may know the drug called Flomax, also known as tamsulosin. And what tamsulosin does, it actually causes what we refer to as a retrograde ejaculate, where the ejaculate upon orgasm doesn't come out, it goes back into the bladder. And that's specifically relating to the alpha blockers, which relax the bladder neck, and so there's no blockage at that level. And when the ejaculate happens, there's actually less blockage going down than up. I'm sorry, up than down. And so it ends up going into the bladder. But, if you get off the Flomax, it returns in a long time, though. It usually takes about 6 months after getting off the Flomax or Tamsulosin for the ejaculate to return. Yes, sir.
Thank you for hosting this. Appreciate it.
Thank you.
We did have our consult yesterday.
Oh.
So I had a question regarding low risk prostate cancer. I know when we were reading and watching some YouTube, they talked about just doing brachytherapy without the radiation therapy component. Is there a reason why we have to do the radiation component and not just do the brachytherapy?
A long time ago, I was doing brachytherapy alone. I had the largest series in the world doing brachytherapy as a solo treatment. And it really looked like a great measure for patients having prostate cancer, because I was actually walking away or running away from doing the radical prostatectomy. And it was so easy, so simple. We weren't getting into issues with incontinence and could preserve sexual function. So that was a wonderful thing. Wasn't losing a lot of blood. And so concerns of spreading cancer at a time of procedure were diminished substantially. But what I came to find was that there was a PSA trend of going upwards, not in everyone, but in enough to get my attention. So let me just give you kind of a drawing of the prostate so you can understand it. So the prostate, first of all, is shaped something like this, where the bottom is smaller than the top. And we call the bottom the apex, we call the top the base. We often talk about it being like a small fruit or a walnut when it's really like a heart, okay? And then, of course, it has a right-left side to it, and the prostate urethra goes right down the center of it, and all urine has to go through that prostate urethra. So it has a lot to say with respect to urination and side effects, generally speaking, because as the prostate gland gets larger, it can push on the central pipe, or it could push up here, because up here is a really big muscle that we call the internal sphincter, which is actually part of the bladder, which is off this page, and it's much bigger than the prostate. But and the bladder wall thins out, but at the bottom of the bladder, top of the prostate, is this big muscular sphincter that we call the internal sphincter, and it's the control center for urination. Between the prostate and the bladder are those appendages that I was referring to that collect the ejaculate. And the prostate makes most of this, we call it seminal fluid, which is the same as ejaculate, and stores it in the vesicles above it, or reservoirs above it. These reservoirs called seminal vesicles make some of the ejaculate too, about 10 to 15%, but most of it is made by the prostate. Prostate's a very busy location, so the bladder, while I'm showing it to you above, it also falls in front of it, and it's kind of tethered to the front of it. And what is not on this diagram is the rectum behind it, and alongside of the prostate here are big bundles of nerves, arteries, and veins, which we call the neurovascular bundles, and they're running off to the penis. The prostate empties out into an area here, and right about here are additional sphincters that we call external sphincters. So this is the big internal sphincter. These are the little external sphincters. And they don't have a lot to say with respect to urinary control. But, they can be built up with things like Kegel exercises and other pelvic floor muscle exercises. So the big deal with prostate cancer tends to be the way that cancers develop, and they more often than not begin along the edges of the gland. Whether it's down below or up above, it could be up over around here. But they begin on the edge, and we call that edge the peripheral zone. Okay, and the peripheral zone is where most prostate cancers begin. That's not to say they can't begin somewhere else. They can, but most are on the edges here. What makes the prostate very interesting is that it does not have a capsule. And you can think of capsule as a layering around an organ or a sheath or a membrane or a barrier of sorts. Most things in the urinary system and most things in our body, most organs do have capsules. The prostate doesn't. And so the interesting thing about that is cancers have this propensity to send their feelers into the tissues around them. And the prostate tissue itself is fairly inviting to do that. And when a cancer does do that, these little tentacles or fronds are microscopic. You can't see them. But there's a high probability of them being there. And that's the reason why I was just mentioning about treating the whole gland of the prostate to a microscopic dose, because you may just have those tentacles that we don't see. But what happens, you see, is that because of the fact the prostate doesn't have a capsule, then the cancers leak out like this, and they can do that pretty easily because they're kind of just doing the same thing that they're doing in the gland, but they're going on the outside. And so when I was doing brachytherapy as a solo treatment, there was a certain style that I was using. It was called a peripheral loading pattern, and what that basically meant is that I would high dose the gland itself and put numerous seeds in it. But then I would also realize that, well, I got to treat the potential microscopic cells in the gland as well. So I did something called peripheral loading, where I would put seeds kind of around the gland as well. And I often describe this as being, if you think about it, these little seeds being like, heaters, space heaters. And if that's the case, and if you happen to be sitting here in the middle, well, all the seeds are contributing to the middle. Okay, so they're contributing their heat to the middle. And so that this area gets, it gets warm, maybe not hot. There's a group in Seattle, Washington, who followed our lead. I was doing this in New York, prostate brachytherapy alone with the peripheral loading pattern. There was a group in Seattle then who started putting seeds in a uniform loading pattern where seeds would be placed uniformly. Every seed was equidistant from every other seed. And what we came to find out about that was the center, which is where there's hardly any cancers at all, but where your urethra lives, which is a sensitive organ to radiation, would get between 8 to 16 times the dose of radiation as it would out here. Meanwhile, the cancers are out there. So that's that. So what I came to realize, though, when I was, when I first did radical prostatectomy, I was seeing PSA failures. I knew that radical prostatectomy was cutting through cancers and spreading them into the bloodstream. But I knew brachytherapy was not doing that. And so I was a bit puzzled, why is the PSAs rising again? I didn't know about this capsular phenomenon, but I came to find out by spending a lot of time reviewing what we call whole mount prostates, which is when your prostate is surgically removed. And you look at it and under a microscope to find it didn't have a capsule, and most cancers have this propensity to escape the gland. And that was the reason why, my precision of radiation is very, very precise. And so even a point, right here is not going to get a very high dose from the brachytherapy. And so in essence, you are underdosing the outskirts, and that's the problem. And it was because of that I started the development of external beam radiation combined with a seed implant, because that was catching everything. So I was getting, again, I was still treating with a relatively low dose to the whole gland, but it could be a microscopic dose if I was just using the radiation alone. But the complement of the brachytherapy and the external beam seemed to do the trick with a lower rate of side effects too. Even those irritative side effects were lessened by the combined approach, because you're giving a little of each rather than a lot of both. So when I was doing brachytherapy alone, well, I had to get the whole job done with the brachytherapy materials. And so I was giving a higher dose, and there would be more irritable symptoms, whether it was rectal or bladder. Whereas when I combine the two, and again, give a little of both with some external beam, which here is DART, and the brachytherapy, it just lessens the side effects. The other side to this is there happens to be these little organs which live outside the prostate. And we call those little organs lymph nodes, and they run on each side of the prostate, and they're very rich in that area. So there's just lots of them. And we have lots of lymph nodes in our bodies. I often say there's more lymph nodes than vessels, and they are part of the filtration of our body to get rid of junk stuff that's not supposed to be there, inflammation, infection. That's how it goes. If you did nothing if you didn't lance a pustule, it's going to be eventually removed by your lymphatics. And there's not many places in the body that don't have lymphatics. The brain has some, not a whole lot. It has its own way of getting rid of things. But cancer is seen as foreign, just like infection, just like inflammation. So these lymph nodes grab it up early on. Right here, we were doing a test between 2009 and 2019. So we had a really good experience, and it was a nanoparticle test. And we called it USPIO. It stands for ultra small super paramagnetic ferrous oxide nanoparticle. And we had the largest series in the world. We were working with University of California, San Francisco, a doctor from Harvard, and a university in the Netherlands, and the University of Nijmegen in the Netherlands. And we had the largest series of its kind. It was amazing in terms of how much it can show in terms of lymph node dissemination. And it showed us very clearly how these lymph nodes had microscopic disease, because it was the only test that could pick up on such small time disease, because it was a nanoparticle. We actually had the benefit of doing that and PSMA PETs, which I don't know if you know, but there's another test for staging now. It's called PSMA, which stands for prostate specific membrane antigen, and it's a way of looking for cancer that may have spread or cancer in the prostate itself. I rarely see lymph nodes involved with PSMA PET scans like I did with the nanoparticles. In 2014, the first place in the country to do PSMA PET scan was the University of Michigan in Ann Arbor, and they looked around and they wanted to see like who else is doing high-tech studies, and they found us because we were doing the nanoparticles. So they invited us to be part of their protocol, and we gladly join them because it would be free for my patients to get PSMA PET scans. But what it did for me is it gave me an idea of, the two studies back to back, because we were still doing the nanoparticles, then they are getting a PSMA PET scan. And the PSMA PET scan was not nearly as good as the nanoparticles. And it's unfortunate we don't have the nanoparticle test anymore. The only place that it's available is the Netherlands at this point in time, but it was a really great study. I've tried to get it back, but it just doesn't seem possible. Anyhow, does that?
Thank you, doctor. That does answer my question. So, as a result of the low dose inside the organ through brachytherapy and the low dose of radiation, are you seeing any recurrences of cancer, or are we pretty much getting?
He's asking, with this combined approach, are there recurrences of cancer? And it's low. It's possible. I just did a biopsy in a patient of mine. Really rare for my patients to get local recurrence. I felt really bad, because we cover the territory, but it did, he did have a recurrence, but it's so rare. And I looked at that. I said, I haven't seen one of these in a long time. So it's a very low probability event where cancer comes back in the prostate itself. Most people who now, with this combined approach, if there's a PSA elevation, it's typically not so much in the prostate gland. It's because it had dispersed either before we ever treated a patient, to liver, lungs, bones, and things like that, and probably that's the reason why, or there was just advanced cancer out here sticking around. By the way, the lymph nodes sometimes they can be enlarged even by a PSMA PET scan. But you see, lymph nodes, the transit is always going up, never down. So they start in our toes and they end up in our neck. And it's an upward drainage pattern. And Actually, the only place they're going down would be from the back of the ear to the throat. So right here to here, that's it. But they're always going up, and they're moving. They're moving along. They get rid of junk. That's their purpose. They move up until they finally gain access to the vascular network and shed into the bloodstream. And that's what happens with, as I say, junk, stuff, infections, inflammation in our body. But it's always moving up. And what happens, it seems, with prostate cancer is that most cancer in the lymph nodes is microscopic. So you can't really see it too well with a PSMA PET scan because it may be here, but not hang around long and move up to the next stage and move up to the next stage. Never quite has the time to hang around and become a big lymph node. But that can happen. And that can happen when you have a higher Gleason scores, 8 through 10s, because they are growing faster. So even though they're only meant to spend a small time in this lymph node, even that small time can cause the enlargement of the lymph node. And we can pick that up also. We do here, I like doing light speed helical scans of the body to try to pick up on spread of cancer, wherever it may be, whether it's lymph nodes or bones or liver or lungs, things like that. Okay, you're welcome. In the back.
John here. Yeah, I was just wondering,
Oh.
do you have any idea what actually causes men to get this prostate cancer?
Yeah, so he's asking what causes prostate cancer, and unfortunately, we don't know. We know things that put you at a higher risk for developing prostate cancer, and that could be having, a familial relative who has prostate cancer or one of the other cancers which are related to prostate cancer, and there are many, and that's in women, breast cancer and ovarian cancer. If you have men have a relative who has that. Colon cancer, pancreatic cancer, and melanoma are related to the prostate. So it does put you at higher risk. African American men have a twofold increase in developing prostate cancer compared to white men. Then there's the environment. Sometimes, we now know, for example, Agent Orange in Vietnam War has a high probability of causing prostate cancer and other cancers. It was definitely carcinogenic. And then, who knows what you've been in, you've come across in your lifetime, what pollutant, what toxin, what, you just don't know. And then, of course, there's diet. And we now know that those countries and populations which abide by a healthier diet, which is mostly a Mediterranean diet, but also an Asian diet with fruits and vegetables mostly, and not getting their proteins from red meat and pork, and those tend to be the two bad guys. They do have. So diet is really important. And so if you look at populations that eat by the Mediterranean diet or the blue zone diets or an Asian diet, far less rates of prostate cancer. Case in point, in Hawaii, not anymore, Hawaii is pretty much westernized, but in the past it was looked at, and Hawaiians had a very low rate of prostate cancer in Hawaii. Then they moved to the States, and second generation is equal to Caucasian males. So, it speaks volumes for either maybe there's a virus here that we don't know about, we haven't detected, that's giving prostate cancer, and that's a possibility too. But we think it's probably the diet. And but there's familial tendencies are also really important. And so I always ask people if they do have a first degree relatives. Smoking and alcohol, can also have slight risk in promotion of prostate cancer, not as much as with other cancers. And one of the other interesting side notes is that you'll all hear, I got cancer, stop sugar, right? Sugar does not directly feed prostate cancer. It also doesn't directly feed kidney cancers. That's very interesting, because what we do with cancers, wherever they may arise, once you have a cancer, we do these tests called PET scans. A PET scan shows activity of a cancer. It doesn't just show where there's a cancer, it shows where it is, but its activity. And that activity is subject to something we call an SUV counter. And the SUV counter says, okay, there's something there, and it's growing pretty fast, or it's growing pretty slow, but it's taking up the molecule that we injected. So for most cancers, we inject the fructose, a sugar molecule. And those sugars go off, and if you did have, you see patients with cancer in their lungs and liver and bone, it grabs it up right away because those cancers really like sugar. If you gave a sugar injection to patients with prostate cancer, you wouldn't find it. And for that reason, we're fortunate because just like men are fortunate, to have the PSA test, which is specific. It's the only organ in the body that has such a specific and sensitive test. We now have the PSMA PET scan, which, similar to PSA, uses prostate-specific membrane antigen to identify it. So in the same way, you're injected about 45 minutes before your scan with the PSMA tracer, and then you scan and see where the PSMA went to. So that's kind of what it's all about. So, but having said that, there's another angle, and that is that sugars cause inflammation. Okay, just like processed foods. So the big baddie with cancers, including prostate, is inflammation. So you got to look at what causes inflammation. Well, red meat causes inflammation. Pork causes inflammation. Processed and ultra-processed foods cause inflammation. So does sugar. So from that angle, it can, promote prostate cancer, but less so than with other cancers, which directly feed the cancer. All right. I think the gentleman, yes, sir.
You mentioned the gel. What happens to that over time? Does it just dissipate or?
Yeah, he's asking about the gel that I previously talked about, that spacing gel, which goes between the prostate and the rectum. And yes, it does. It just kind of resorbs by your body and just goes away. And the reason, many men ask the question, why don't we do it right from the beginning? Put in the gel, and we could, but you only get one chance, and it's really expensive. Okay, so if you wanted to pay for the first time and go around, we can do that. But as I told you, the more important time is when I do brachytherapy, and the prostate, which has its seeds, is sitting right on the rectum. So that's when I really want to space it. If I did it in the beginning, it would probably be only 20% less left by the time I got to the brachytherapy, and so it's not really doing its best job. Yes, sir.
I was talking to a friend of mine yesterday. He's got a small prostate, but he's having it done up north for 3 months. And he was saying something about they did like a titanium or something, some kind of metal.
Well, it might be brachy. He's asking about a metal that
It's not brachy.
it wasn't brachytherapy.
It was Stone Age, I guess.
Yeah,
My opinion. But he said they put that between, like what you're talking about.
He's asking about some alloy placed. I don't know. I've not heard of that. I know that some places put gold, what they call gold marker seeds, into the prostate, and they do that so that they can aim their beams and hit the prostate. I don't like doing that because gold marker seeds cause quite a bit of artifact. And so, we're all about looking at the prostate, the tumors in the prostate, and it just obscures things. Not to mention, we believe our treatments are that much more precise. We don't need to do that. That may be it, because the gold marker seeds have titanium casings. Okay. I think there was someone back here. Yes, sir.
How effective is radiation for bone, helping bone lesions and other side effects?
Repeat that one more time.
How effective is radiation for helping bone lesions and other side effects?
He's asking the effectiveness of radiation in bone cancers. And radiation is a very effective treatment for cancers wherever they may arise. what happens is radiation produces something we call free radicals. Free radicals hit the DNA strand, which is in the cancer. Just like normal cells have DNA, so does cancer. And it fractures the DNA and the cancers die. So wherever cancers may be, and this is not only prostate, but it could be lung, liver, tongue, wherever, if it's spread to bones, radiation has a very good chance of eradicating it in bone. It's very effective in doing that, and it's time tested. It's been around forever. As it pertains to side effects, it just depends on where that bone is located. But again, with really accurate measures these days, precision radiation, you don't really get much in terms of the side effects. Sometimes, if there's cancers in bones in the head and neck area, then it's really close to things that can get bothered by the radiation. But by and large, not a whole lot of side effects with respect to radiating bones. Mm-hmm. Yeah, he's asking about maybe marrow. So bones carry something we call marrow, which is which causes your blood vessel, not blood. It's a progenitors for all your blood cells. Okay, your hemoglobin, your hematocrit, your platelets, all those things are made by the marrow and bone. And so what we try to do is we try to limit the field exposure to the bone. But generally speaking, if there's marrow and marrow moves around, if there's marrow moving around in the bone, the radiation is going to treat the entire bone. It's going to treat the entire marrow in that bone, and it will affect the marrow in that bone. It may kill the marrow cells. However, once the radiation's finished, then business as usual as time goes on, and the marrow begins to refill and populate and do what it's supposed to do. Okay, sir.
Yeah, thank you, doctor. I had a question that I'm certain that everybody in this room, when they found out they had prostate cancer, started talking to healthcare professionals. And I was amazed at how many treatment plans there were. And I know I got a really good article from Nurse Julie on your jigsaw puzzle article that you wrote a number of years ago. It answered an awful lot of this, but why is there so many different approaches to prostate cancer? It's the biggest cancer that all men get of all the cancers out there. And you would think by this time the medical profession would agree. And I know that from reading this article, there's been conflict between the radiation oncologists. I realized that you were a surgeon at one point, and the surgeons. And you'd be interested in commenting upon how us lay people have to try to figure out how to get to it. Because there's so many people saying, no, you don't want to do that. You want to do this.
Yeah, so he's asking, why are there so many potential treatments for prostate cancer? Haven't we kind of figured it out? Prostate cancer has been happening for a long time. If you look at most other cancers, if you get one of those, there tends to be treatments that are kind of, this is what you get, and no one's going to debate it. This is how you treat it best. The problem is that in all those other cancers, the best isn't that great, okay? In prostate cancer, the many treatments, the doctors can raise their hand and say, I think mine is more curative than yours. And everyone's going to stand up and say, well, so you're going to have the urologist going to say, well, I think surgery is the best. You're going to have the radiation doctors and say, I think radiation's best. You're going to have the guy who does freezing the prostate. I think freezing is best, because they're all effective. Okay, but what I've always made the case of is they're all effective initially, but which one gives the best long-term outcomes? And I would argue, when all is said and done, that the combined radiation treatment of what I've told you, the radiation plus brachytherapy, beats it all out. And, you don't have to take my word for it. Go to AI now. You could ask AI, go through all the data and figure it out. There's another interesting side note to that, and that is, if you can follow me with this, the studies which have looked at radiation versus surgery, okay? And, they're well-run studies, and, some guys are getting, and typically it's for localized prostate cancer. They'll say, okay, we're treating localized prostate cancer, and this group is going to get radiation, and this group is going to get surgery. Remember, it's localized. What happens is, and now we're going to look at the data 5-10 years later, okay? So the guys that have the surgery, they get their surgery. However, at the time of surgery, they're found to have more advanced disease than you thought. The CAT scans, the ultrasounds, the MRIs didn't show that extra prostatic extension, which is very common, by the way. It didn't show the fact that the cancer had invaded the direct, for example, the seminal vesicles, the bladder, neck, going out to the neurovascular bundles. But they find that at surgery, and when they do, those group of patients are excluded from the data because they didn't have localized prostate cancer, okay? Now, if you think of the same scenario, the guys going through radiation, they got localized prostate cancer based on their staging. No one's going to be excluded. So in many respects, the surgical data is berry picking out the bad actors. Do you follow me? And so what ends up happening is you're asking, you're looking at apples and oranges because they're not apples and apples. And that's unfortunately the way the data has been collected in the big studies that have compared radiation and surgery. So there is a bias, that surgeons have. But that's not to say you can't be cured with radical prostatectomy. You can. It's just that, again, I look in the long term, like who's got the really long data, the 10 years, the 15 year, who's got it in showing the best outcomes. And there is a study right now, it's called the Ascend-RT trial, and they are looking at within the radiation realm, because then you'll get the radiation doctors and they'll say, oh, we're just going to do radiation alone. Or you get the guys who maybe brachytherapy alone. But if you look at the data, again, the Ascend-RT trial, it's a North American multi-institutional trial. And what they did is they looked at radiation alone to radiation and brachytherapy, and they find that there's 50% less recurrences with the group having the combined approach, the external beam and the brachytherapy. And I think there's probably good reason for that. One is that you are getting higher doses to tumors with the brachytherapy. Also, cancers, they're smart. They like to resist whatever we do. And sometimes you give them one kind of treatment, radiation alone, and you get some malignant clonogens, which are just defying what you're doing. And they're trying to escape the wrath of the radiation. And they're getting, by the way, high dose radiation from the protons, photons, neutrons, or electrons. They're all the same. They give high dose radiation. I think that the combined approach, suddenly you give brachytherapy, it's a completely different animal. The cancer hasn't seen it before and it dies. And this is what we're seeing in many sites of the body, that you may read about: breast cancer, lung cancer. There always appears to be advantages when using multimodality treatments, when you just don't use one, you combine it with something else. Patients with prostate cancer, it appears that those having more high-risk features can benefit from hormones delivered simultaneously with the radiation. And the data has, it dates back to the 80s, showing that advantage. And it appears that the radiation, again, does its killing with striking with free radicals, the DNA of cancers. But in the small percentage that may try to defy that and escape, the hormones don't allow it to repair, and it dies. But that's more important, it seems, for higher grade tumors and not for the lower grade tumors. So basically, we all have something that we could say it's effective in the short run. Okay, and I was, I used to be a short run person until I started looking at it the long term, and that's when I see there is a real difference in outcomes in the longer term, and that's important. I'm not a big fan of the the freezing and the heating of the prostate, because you're basically, what you're doing is you're saying, okay, I'm going to come in with a needle and ablate this area right here. Number one, you can't go outside the prostate because if you do, you're in territory that's going to damage something. So you got to stay within the prostate. And the historic problem with prostate cancer, as I was mentioned earlier, there just may be microscopic cells because after all, they've all been subject to the same cues, whether it's your genetics, whether it's environment, whatever it might be, napalm, they've all been subject to it. And over time, they're going to develop cancers. And that's a problem also that I've seen in men who have radical prostatectomy. And the reason I believe I've seen that is I've been looking at the prostate for a long time, for decades, and I've never found a patient who's had their prostate removed surgically, radical prostatectomy, and the entire gland is removed. Never, not a single case has ever been that way. There's always tissue left behind. And so if you just think about that, even in the event that there wasn't this escape outside the gland, which is very common, and you really did get it all, but you're leaving some of the prostate behind. And that prostate left behind, again, tends to develop cancers over time. It may be 5 years. I have a recent patient that was 21 years after radical prostatectomy, and that's rare. But, it could be anywhere along that line, 5 years to 20 years, and so I see that, we call it late recurrences, and I don't see that in the patients treated with a combined radiation regimen. Now, some patients here, we do treat with DART alone, and when that happens, I do treat to a very high dose. And, I do tell men who have the option, they can do that. And, there are guys who don't want to have any kind of procedure, even brachytherapy, which is a pretty short and simple procedure, but I don't have the data right now. I can't say, well, in our guys who had the DART that I could treat to a very high dose with the DART alone, how do they compare to my combined modality group? I don't know that yet. Time will tell. Let's see, ma'am.
I have a question. I know this is prostate cafe, but you also treat some breast cancer. So this is a question for us girls. Many of the things that you said help prevent or keep us healthy would go for us girls as well. The diet, is that correct?
Yes, definitely. Yeah, so she's asking, breast cancer prevention. It's the same. It's the same with every cancer. Every cancer, in fact, most diseases thrive on inflammation. And so, we strongly believe, if you could, and it doesn't mean you can never eat red meat or pork, but just moderate things. Just don't eat it, 3, 4, or 5 times a week or more, as many people do. And try to, take away things that cause inflammation that I've already mentioned, and go the other direction and try to consume things that actually reduce inflammation. And we do know, for example, I don't know if you like avocados, but avocados are not only the most nutritious food that I know of on earth, but they also are powerful anti-inflammatory foods. Extra virgin olive oil, same, very powerful anti-inflammatory food. So, it's kind of food. So, you go into that direction. And interestingly, with the prostate, there are also some ingredients that prostate cancer doesn't like. And that's an ingredient that we find in red things like red tomatoes and cooked tomatoes specifically. It's called lycopene. And lycopene isn't red tomatoes, comes out a lot in a cooked tomato, as it does in, other red things. Watermelon, red papaya, red grapes, red beets have this lycopene in them, and is very effective. There have been studies about that too. Prostate cancer is interesting. There have been population studies which have demonstrated that dairy is not good with prostate cancer. Don't know why that is. Maybe it is a form of saturated fat. If they were just consuming maybe skim milk or 1 or 2%, maybe it'd be different. But in the studies that have been done, it has been documented that it's not good for prostate cancer. Whereas other cancers like breast, I don't know of any such data. or dairy is bad for breast cancer or colon cancer or lung cancer. I don't know that, but it is for prostate, and there are pretty good studies and a lot of them. Yes.
Regarding the daily molecule for prostate cancer, is it should be related to like milk or also processed dairy like cheese or yogurt?
Good question. She's asking, is it just milk? Okay, and I think, and I've looked at this, probably mostly just milk. Okay, but and for example, we also know that populations that eat sheep cheese, goat cheese, and Greek yogurt is fine. It may even have a lesser degree of cancers. Okay, if that answers. So, but yeah, it's mostly milk. Yes.
Your patients who undergo DART obviously will have some side effects. Typically, what type of side effects can the patient expect and how long do they linger?
So she's asking about side effects related to DART, and we treat here, we do it every day, and some guys will have zero side effects, and others will have more side effects, and we, sometimes we scratch our head because we really don't know why. But there are some clues, though. In some men, their prostates are really large, okay, and it's just more territory to get inflamed, and that can cause some side effects from the radiation just because the largesse of the prostate gland. There are other things sometimes I see, and that is if my fist is the prostate, but if it has this portion of it like that, we call that a median lobe or an intravesical lobe. It's kind of like your thumb sticking right into the bladder. And if your prostate gets inflamed because you're being treated, it can share it with that finger, and then it's going to irritate the bladder, and that can give more frequency and more urgency. So it just really depends on some of the, but there's going to be some guys, they just have side effects, and we don't know why. Their prostates are not large, but we often know that if you go back and look at their voiding profile before their radiation, if it's relatively high, if they're already having some frequency, some urgency, some nocturia, getting up at night, they may be the guys who have more side effects than the guys who don't. So, but
And they do wear off.
they wear off. They're temporary, and we try to micromanage, with anti-inflammatory foods and drugs and alpha blockers, which relax the prostate tissue and the bladder neck. Okay.
That's the same with brachytherapy as well.
Same with brachytherapy. Yes. Mm-hmm. Yes.
He had to go down for treatment.
Oh.
So he asked if I would ask for peace and love. Previously, he was diagnosed with was having like frequency, a lot of that, and then like he said after the cancer will now correct itself, or will we have to have other treatment?
So she's asking about, again, side effects, basically, and once it's all said and done, the other variable with cancers is that if this is the cancer, and you mentioned Gleason 9, so they usually get pretty big, and they start pushing on other things, okay? And the cancer itself can cause side effects, okay? Because there's only so much room in the prostate. It's, even though I say large prostate, it's never that large. It really isn't. But if it's pushing onto structures, well, if you just think about that, you're treating with radiation. Well, as I was mentioning, we hyperdose this area with the DART or brachytherapy, and it could then share the inflammation with everything that it's involving, it's invading. And that could even be in the backside, the rectum. And you get rid of the tumor and you get rid of the radiation because you're finished. The inflammation goes down, the tumor goes down, and then everything relaxes and goes back to its normal self. So that's the most common pattern that I see with men being treated. So, and you know, also sometimes when men have higher Gleason scores, you know, like 4 + 3 = 7 up to 10, I treat with higher doses. I know I have to, you know, to get to the tumor itself and eradicate it, you know, permanently. So that could also result in some more side effects as a result of the radiation. Okay, yes.
That chemo patients typically are immunocompromised. With the radiation therapy, is there any risk of immunocompromised?
So she's asking if patients having radiation are immunocompromised, and the answer is absolutely not. It's the reverse. So it's very interesting that whereas chemotherapy plummets your immune system, surgery drops your immune system, radiation upregulates the immune system, makes it stronger, as do hormones. Hormones also cause a profound strength and, you know, upregulation of the immune system. And some of the thinking I mentioned with hormones before, not allowing the cancer cells to repair, you know, the breakage of the DNA. The other current theory, because we talk a lot now about immunotherapies and PARP inhibitors, and we do them here, we do a lot of it here. A lot of those therapies actually bolster the immune system. And it appears that you give them together, radiation and the hormones, that 1 + 1 ends up equaling like a 4 or 5. It's a super added event. And that's why we do refer to hormones as sensitizers for radiation. So it's the opposite. So in fact, everything with radiation and hormones is strengthening the immune system. Yes, sir. Last question. This is
Wondering, I hear some guys have to go for more radiation than others. Does that pertain to small prostates and large prostates?
he's asking about the, you know, how many radiation sessions and, you know, more or less radiation. There is a model that, you know, translates into lesser cancer, less need for treatment versus higher cancer, but there's a whole lot of other things too, because sometimes a lower risk cancer has some microscopic element going to lymph nodes, and we have to boost up those lymph nodes to a higher dose. Every case is kind of individualized here. Okay. Anyhow, well, thank you for coming. Again, we'll do this again next month. Bye-bye.